Hi, so my name is Jennifer. I work at Rush Hope Park Hospital. I have been in speech for the last 5 years, and I have had experience working with patients who have myasthenia, primarily in the inpatient hospital setting, typically when they're having a myasthenia crisis. In speech and swallowing therapy, what do? Again, oftentimes I have come across patients with myasthenia in the hospital when they're having a crisis. The big thing is we work on compensatory strategies. In a crisis, we do not do exercises because the exercises are going to lead to fatigue. So one of the things that we will work on is trying to plan meals in conjunction with the timing of medications, diet modifications, strategies like smaller meals but throughout the day. So instead of 3 large meals, maybe 5 or 6 small meals. Alternating solids with liquids. Another one that I've found to be very successful is to have foods on the plate that need to be chewed, but to also have foods that don't need to be chewed. So naturally pureed items like mashed potatoes, yogurts, easy things like cottage cheese, to have a nice mix at your meal so you don't have to necessarily change the entire diet to a pureed diet, but you can balance it with different types of food on the tray. Resting before the meal, that's a big one, especially in patients who are having a myasthenia crisis. If you're weak and you're having a hard time, I have often said wait until you have some rest before you have your meal because it's only going to get worse. Positioning changes. So with this, if you remember I was talking about the modified barium swallow, one of the techniques that has been very effective in patients with myasthenia is to do something called a chin tuck. And basically what that is you tuck your chin down to your chest when you swallow. And the rationale behind that is that it decreases the airway space and it increases that molecular space, so you have a wider space for the food and liquids to go down. So you put yourself at less risk of aspiration. Some of the other things after the crisis is over, you may do exercises. The important thing though with that is that you are doing them while you're being monitored by the speech therapist. And the reason is because there's a fine balance between strengthening the muscles of swallowing to the point of the next time you have a crisis, maybe the dysphagia won't be as severe, versus working on exercises but becoming so fatigued that they're inefficient and ineffective. So you may be prescribed exercises and you would do them with your speech therapist and the recommendation of your physician as well, but you're going to do them really under close supervision because you don't want them to fatigue you to the point where it interferes with the swallowing, because then it's not effective. So, my next slide talks about a feeding tube. So this is a question I have come across many, many times. And this really is something that I don't recommend unless the dysphagia is so severe that there is no safe diet that could be given. So that would mean, if we tried thickened liquids, we tried the pureed solids, and it really shouldn't be implemented unless it's absolutely necessary. And there are different types of feeding tubes. There's temporary ones that kind of go through the nose until the crisis has started on its way. It may be like day 1 and you're just starting the medications, but by day 2 you're better, so feeding tube may not be a consideration. So this is really something, I've been asked this question a lot, and it's really up to the medical team when you're in the hospital as to whether or not this would be appropriate, which would be your physician and the speech therapist, and they would be working together. Okay. For speech therapy and voice therapy, which is often the complaint at discharge from the hospital, so we really focus on the compensatory strategies. We would focus on working on improving the accuracy of articulation, decreasing the nasality. We have this little thing that we use, it's called a C-scape, and when you talk, we put this little tube right here by your nose, and what you want to happen, it measures the flow of air from the nose, and you want to decrease it, so we use that as a feedback tool. Working on shorter utterances, so shorter sentences, shorter statements, taking small breaks, so let someone else talk for a minute. And if it's really severe, you can use a communication device. There's all kinds of communication devices out there. You'll hear like high-tech, low-tech. You may hear them called AAC, which is augmentative and alternative communication. It could be as simple as just a communication book, or it can be an electronic device. If the myasthenia is so severe that oral communication is not really feasible, oftentimes we've had a lot of success with the electronic devices because the cognition is still intact and the comprehension is intact, so you can train to use a device, which are really nice. We also work on things like breath support, which is essential for speech, working on coordinating breathing and swallowing. So your speech therapist may have you do activities such as blowing through a straw, or it's called resistive sucking through a straw, where someone's kind of occluding the end of the straw and you're trying to suck on it. You're working on pulmonary support when you're doing those kinds of activities.